Good morning, everyone. This is Sarah with the Iowa Healthcare Collaborative, and thank you for joining us for our final CEU or Nursing Contact Hour webinar during our Opioid Guardianship project. Today we will be talking about addiction identified, now what? And we have two really great speakers that are going to share their experience with how to go about treating opioid use disorder or substance use disorder and what they have done in the past and what they're working with their patients currently. Just a couple of reminders for our webinar today. Please mute all of your phone lines. This is just to make sure that we do not have any background noise, and that way we are able to have our speakers speak very well throughout this entire presentation. Also, please do not place the call on hold, as we oftentimes will have that background noise. I am going to try to mute you all, but I do appreciate if you mute yourself as well. Please use the chat box for any questions that may arise throughout the presentation, and we will address those at the end of today's presentation. And then this session will be recorded and available on HIDTA following today's presentation. To obtain nursing contact hours for this session, you must have entered your nursing license number at registration. You must be logged in individually with a unique email address to the webinar for the full duration of today's presentation. No partial credit will be granted. And then the nursing contact hours certificate will be emailed to you following today's session. If you are not obtaining nursing contact hours, there will be a certificate of attendance available. After the webinar, you will receive an email link to the evaluation, and for all disciplines except nurses, a certificate of attendance can be printed after completion of this evaluation. So our first speaker today is Dr. Nicole Gustala. Dr. Gustala is a graduate of Loyola University Strick School of Medicine in Chicago. She completed her residency at the University of Iowa in family medicine. She was chief resident in her third year and is a board certified in family medicine. Dr. Gustala was also a visiting scholar at the Robert Graham Center in Washington, D.C., where she focused on health policy analysis relevant to primary care and family medicine. She is currently a family physician at Primary Health Care in Marshalltown, Iowa. Her interests include treating the whole family, women's health, children, adults, and elderly, with a special focus on preventative health care, group visits, chronic pain, and medication-assisted treatment. Welcome, Dr. Gustala.
Thank you. Well, hi, everyone. Thank you for joining us today. We're going to be talking about medication-assisted treatment. So specifically, after you've identified a patient as having a substance use disorder, particularly an opioid use disorder, kind of what to do next. So, hey, Sarah, am I going to be able to advance the slides, or will you be advancing?
I will advance them for you.
Okay, great. You can go to the next slide then. So chronic pain and the public health crisis. So about 11.2% of the adult US population has a chronic pain diagnosis, and there's about 3 to 4% of the US population that are on a long-term opioid. There are more opioids in the US than there are in the entire world. There's really a lack of evidence for greater than 12 weeks of treatment, and this has really changed, right? Because if you go 10 or 20 years ago, there was this emphasis on pain as the fifth vital sign, and that we weren't adequately treating pain, and that opioids, at the time, they were saying that there was no long-term negative effects, that they weren't addicting. Well, of course, we've come to see that not only are they addicting, but there also really isn't great evidence to continue them beyond 12 weeks. It puts the patient at higher risk of addiction, as well as tolerance and hyperalgesic syndrome as well. One of the biggest challenges as we are moving, as we moved to opioids to treat chronic pain, is the significant amount of opioid overdose deaths. There's about 1.9 million patients in 2013 who abused or were dependent on prescription opioid pain medications. And if you look at a general primary care practice, the opioid dependence percentage of the practice can range anywhere from 3 to 26%. And about one person dies every 19 minutes from prescription drug use. So how do you diagnose someone for opioid use disorder? Well, there are two different mechanisms you can go about. There's the DSM-5 and the ASAM criteria, and both of them are important in looking at it. So we're going to talk about the DSM-5 because that's more from the medical side, whereas ASAM is a Society of Addiction Medicine, and a lot of that is used within the therapist side or the counselor side. It determines kind of the intensity of the treatment spectrum in terms of do they do intensive outpatient, intensive inpatient, group visits, that sort of thing. We talk about the DSM-5 criteria. This was created by psychiatry. And you want to look for a problematic pattern of opioid use leading to clinically significant impairment or distress. And it's usually manifested by at least two of the following and within a 12-month period. So opioids are often taken in larger amounts over a longer period than was initially intended. So if you're having that discussion with the patient and they're requiring more and more, or it's longer, their pain is out of proportion and they want opioids for longer than it's really recommended. There's a persistent desire or unsuccessful effort to cut down or control opioid use. There's a great deal of time spent in activities necessary to obtain the opioid use the opioid to recover from its effects. So if there's a lot of doctor hopping, they're going to ERs frequently, this all should be a sign. There's a craving or a strong desire or urge to use opioids. Recurrent opioid use results in a failure to fulfill major role obligations at work, school, at home, that's really affecting their life. Continued opioid use despite having persistent, recurrent social or interpersonal problems caused by or exacerbated by the effects of opioids. There's also a problematic pattern of opioid use leading to clinically significant impairment or distress as manifested by at least two of the following within about 12-month period. So there's important social, occupational, or recreational activities are given up. So if your patient all of a sudden used to love fishing, doesn't go anymore, used to ride their bike, used to participate in their children's baseball games, these are all kind of signs. They were a coach for their team and they're not doing that anymore. They're not showing up to work. This would also be, or they have lost a significant amount of their friends or family, their support and relationships. There's recurrent opioid use in situations which are physically hazardous, so meaning they're using opioids while they're at work, operating heavy machinery while driving. All of these are part of the diagnosis that you can use. Continued opioid use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the substance. So a patient accidentally overdoses and does not really recognize that they have a persistent problem, which is something that we see, regularly in the media, especially with different Hollywood actors and actresses and musicians. We see that they will have issues but will persistently use and unfortunately sometimes pass away. There's also the diagnosis of tolerance. And so a need for markedly increased amounts of opioids to achieve an intoxication effect or desired effect, so feeling that high, and a markedly diminished effect with continued use of the same amount. But don't use that specific criteria for those taking opioids solely under appropriate medical supervision. And so those are the kind of DSM criteria that I would use to diagnose someone with opioid use disorder. A patient will have a problematic pattern of opioid use leading to clinically significant impairment, again, within a 12-month period. They'll have withdrawal, and this is characteristic of opioid withdrawal. And opioids are taken to relieve or avoid the withdrawal symptoms. So when we talk about withdrawal in patients, they usually get diaphoretic, so have a lot of sweating. Their pupils will change. They will get really nauseous, diarrhea, muscle cramps, kind of feels as if they're having the flu. You want to specify if the patient is in early remission. So that means 3 months of no criteria being met with the exception of cravings or sustained remission, which is 12 months or longer. Whether they're on maintenance therapy and as well as if they're in a controlled environment. So for those patients who are in the hospital or perhaps in a residential treatment facility, that is a controlled environment where their access to opioids are restricted. So you've identified your patient as having opioid use disorder. What is your next step? Well, there are three medication options that are approved, and I'll show you them on the next slide. There's methadone, buprenorphine, and naltrexone. Methadone, we cannot prescribe that outside a registered narcotic treatment program. So the QCS has it, but most primary care offices do not. The two that are available that primary care physicians or providers can provide are buprenorphine and naltrexone. Buprenorphine was approved by the FDA in 2002, and naltrexone is available both oral or IM. It's usually used for induction onto the long-acting injectable. The injectable was approved for treatment in 2010. So how do these different medications work? Well, it depends on how they're working with the opioid receptor. On the left, you have a full opioid agonist. So this would be your methadone. It works similarly to heroin, oxycodone, and others. And it binds completely. It's highly reinforcing. A lot of the places that offer methadone require daily dosing, so the patients must go in every day because it has such a high diversion potential, and they watch to make sure that the patient's taking it as appropriately. The second class of medication is the partial agonist. So this would be your buprenorphine. So this means that the medication binds to the receptor, but it does not fully activate it. It only activates it slightly. So enough to help with cravings or withdrawal symptoms, but not enough to cause that high and unless the patient's opioid naive. And it's kind of like imagining a circle trying to fit into a square. So it kind of activates it, but not completely. It's really great because has a sealing effect, and it does bind very well to the opioid receptor. The third medication is naltrexone or naloxone. So naloxone is what we use in patients who are had an overdose and we're trying to bring back, right? Only lasts for about 15 minutes. You give that intranasally or inject it. Naltrexone is an oral medicine or a long-acting injectable. It completely blocks the receptor, so it prevents heroin or other opioids from binding to the receptor and activating it. It's really helpful for cravings. It does not help with withdrawal symptoms. If a patient is having opioids on board, it will put them into withdrawal. So it's very important that the patient has stopped using opioids for about 7 to 10 days. So this medication, naltrexone, I think is really great for patients who have weaned off of methadone or Suboxone, but just need that medication on board to help with cravings. It's great for patients who have been have been incarcerated, and so they haven't had access to opioids for at least 7 to 10 days. It's great for patients who have been in residential or hospital treatment at least 7 to 10 days. So once the opioid is completely out of their system, naltrexone is a great option to use. It's also nice because you can do the daily dosing with the oral medication, or you can do the 30-day injectable. It is it's not a controlled substance. It's not easily diverted. So there's really no street value for it, whereas methadone and Suboxone, there is a street value for it. Now, so when I talk about buprenorphine, it comes in two formulations. One is Subutex or buprenorphine alone. We tend to only use this in pregnant patients. Most of the medicines that we use that include buprenorphine, we use ones that have naloxone components. So that would be kind of the Suboxone brand or other brands. And the reason why is that naloxone is very poorly orally absorbed. So if you take naloxone orally, it's not going to work at all, which is why in overdose patients, we have to inject it or give it intranasally. Now, if a patient decides to use their buprenorphine or their Suboxone and try to melt it and inject it, the naloxone will go to the opioid receptor and completely block it, put them in withdrawal, and prevent the buprenorphine from binding. And the reason why that's important is that's the way that they can get a high off of buprenorphine. Buprenorphine, when it's absorbed orally, it is only absorbed about 30%, but if you inject it, it will absorb about 100% and have 100% activity. So that's where patients can get the high. So that's why it's important if you're going to use buprenorphine in MAT that you use buprenorphine comboed with naloxone for that diversion decreased risk. And it is a really wonderful medication. So as I was saying, buprenorphine really has a ceiling effect. It's very safe. So there's a maximum opioid agonist effect is never achieved, even when all of your receptors are bound. And so even if you increase the dose, doesn't matter if they try to overdose on it, they can't really. The only time it's ever been seen in overdose is when they've used it with benzodiazepines or multiple other substances. So how does buprenorphine work? It has a very high affinity for the mu opioid receptor. It competes with other opioids, blocks their effects. It displaces heroin or other opioids from the receptor. This can put a patient into withdrawal if they're not already in withdrawal, which is why it's important that when we start the medication, they're in slight withdrawal. This will help get that medicine on board. It has a slow dissociation from the mu receptor at about 24 hours. It has a pretty prolonged therapeutic effect. It has a ceiling effect, so it's a very poor drug for intoxication purposes, much safer in overdose. And as I said, naloxone is very poorly orally absorbed, but if they try to inject the Suboxone, the naloxone will block the effect of the opioid. So how do you pick the right dose? This is an fMRI or PET scan that was done with the different dosing. So on the left-hand side, you have the BUP, buprenorphine, 0 to 16 and 32. The green areas of the MRI show the mu receptor. And so once you get to about 16, which is most goal dose for patients, you can see that almost all of the receptors are bound or blocked, meaning that it's going to decrease their withdrawal symptoms, it's going to affect their cravings, it's not going to allow another opioid to bind to it because they're all taken over by buprenorphine. If you go past 16 to 24, 32, doesn't really have that much added benefit. So this was one of the original studies done in 2000 that showed the effectiveness of buprenorphine compared to methadone. And what the study shows is what the mean percentage of negative urine drug screens, so meaning consistent urine drug screens in patients after starting. And as you can see, once you get to week 17, you're up to almost 60% of patients that are compliant with the medication and have not used opioids. So this is pretty good when you combine it with therapy as well. So why does buprenorphine work so well? What helps with withdrawal symptoms? So a patient, for example, it's very important to understand that opioid use disorder is an equal opportunity disease. It really affects all patients from all walks of life. So I had one patient come in who was a construction manager. He worked for a company, worked at multiple sites, and the reason why he could never get off opioids, he was given them for back pain, and he couldn't get off of them. No one would prescribe it anymore, and he became addicted and started buying them off the streets. And he couldn't miss enough. He didn't want to miss 2 weeks of work going through those withdrawal and feeling those cravings. And so he came in at 8 a.m. for his appointment. He was in slight withdrawal, so a CAL score of 7 or 8. His last dose was the night before, so rather than taking his morning dose, he waited until he felt withdrawal, came in, we dosed him, and he was able to go back into the work in the afternoon. So it really helps stabilize the patient in terms of their home work-life environment and helps them stabilize so they can do therapy and work on their addiction, and then hopefully, if it works for them, taper off the medication. It helps with withdrawal, it diminishes their cravings, it doesn't produce a high, it'll block the effect of heroin, and it really increases treatment retention. We absolutely 100% require psychosocial services for treating. So the medication is great, as I said, for withdrawal and cravings, but it does not treat the underlying addiction. It doesn't treat those behaviors, those social interactions, the things that they need to change. If they have stress and anxiety, rather than going and trying to find drugs or a hit in order to be able to deal with that anxiety or stress, they need to learn different tools and therapy tools that they can use rather than reverting to that. And so it's really best practice. It's a requirement as part of the DX, and it's also a significant portion of the prior authorizations across Iowa for the MCOs, and also private insurances, and Title 19 requires that they go to therapy, and it's part of the prior auth. And we refer to the therapist or the substance abuse treatment center, and they decide really what is best for the patient, whether it's inpatient, intensive, outpatient. You can do CBT, Narcotics Anonymous, individual group therapy, there's family therapy, 12-step, and sometimes patients who require inpatient or higher psychiatric, those with higher psychiatric severity definitely need more increased services, and they are much more responsive to that as well. So opioid use disorder maintenance therapy. So again, it's important for lifestyle stabilization. It improves health and nutritional status, decreases criminal behavior, helps with stabilization and employment, and then decreases their risk of injection use or shared needles, so decreases hepatitis C and HIV transmission. So why is this all important? Why do you want to offer these medications for your patient? Well, substance use can negatively impact other illnesses. So as we move from towards a value-based system, it's really hard to get your patients to care about their diabetes or their other hypertension or their obesity if they have an addiction problem. It can also masquerade as an illness that the patient doesn't have. Opioids are known to cause severe constipation. Methamphetamines will cause very high elevated blood pressure. It can cause stroke and heart attacks. It will contribute to non-adherence to prescribed regimens. If they're going to only have a certain amount of money to pay for medications, they are for sure going to pay for it to get opioids over their diabetic medications. There's really a lot of toxicities due to drug-drug interactions, and it's a significant contributor to cost containment. So how do you start a MAP program within your own clinic? So I'm hoping that from now you've got that information, you're kind of revved up and saying, okay, now I have some of the tools that I need to know in order to be able to treat opioid addiction within my clinic. So how do I do that within a primary care setting? If you look at Iowa, this was produced in, I think it was the Annals of Family Medicine a couple years ago. The gray dots, or gray squares, I should say, are the counties that have one prescriber. The white areas do not have any at all. This has improved in the past couple years, but still, you see, compared to the East and West Coast, there's a significant shortage of providers who will do MAT. And so this is a great thing that you can do for your community as well as your clinic and your patient population. So it's important to set up your protocol. So what does an induction, maintenance, taper, and discharge look like? Create a patient clinic agreement. What's your referral process look like? How are you going to accept patients and coordinate with psychosocial services? What drug testing are you going to do? What company, the frequency, are you going to do observed or unobserved? It's really important to find a mentor or consider joining an ECHO and focus on team-based care and really whole patient treatment. So I'm a family doc by training, by practice. So if a patient comes in and I'm seeing them for Suboxone, but they've never had their screening labs checked, I do that. I do the colorectal cancer screening, whatever it is that they need to really focus on whole patient care. So the workflow, this is just an example of how we do it in our clinic. They can be referred by the PCP, the treatment center self. They cannot be referred by a family, friend, or loved one, because we really must have the patient on board in order to be able to do it. we schedule them on a special schedule that we have on our EMR. And appointments and consults are scheduled on a day when one of the MAP providers is in the building. They should fill out the controlled substance agreement, meaning that they agree to picking one pharmacy, not sharing their medications, being in control of their medications, agree to random film counts, urine drug screens, that they will be removed from the program if they decide if they sell their drug or divert it. We scan it into the chart with the date, and we do it yearly. We also have them sign a consent for release of information. And we do that to get information from the therapist so that we know that they are going, and also to send information to the therapist or psychiatry as well so they know how the patient's progressing. And you can do that with a multi-party consent, which we created, or you can do it with just a regular two-way. And then we use this as compliance verification to really help make sure that they're attending the behavioral therapy aspect. This is what we created for the front desk to kind of help with the workflow. So a patient calls in, and this is the workflow. If they're interested, they will get referred back to Andrea. If they walk in, then they will also get referred to Andrea, who is our coordinator. And then just kind of works the flow so that the front desk knows what to do with these patients. So what does an induction look like? Well, our protocol we have set up is the patient stops if they're on a short-acting opioid, they stop the night before. Long-acting opioid, they start about 24 hours before. They come in, we obtain the urine drug screen, we review the PMP, we assess the patient's vital signs, do what's called a COW score, which I'll show you in a couple minutes. If their score is adequate, then we give them their first dose. We check on them in a little bit, 30 minutes to 2 hours depending, and keep on dosing up until they feel that their withdrawal symptoms are controlled and their cravings are controlled as well. Then we send their target dose to the pharmacy and follow up in as little as 1 day, or normally at 1 week, and then we're in constant communication in between during that time period. This is what a COW score looks like. So this is kind of an objective way to determine, as objective as possible, determine what level a patient's withdrawal is in. And you really want to get a minimum of 7 in order to start the induction. If they're on methadone, you want that to be a little bit higher, around 14. So you have the patient follow up. We usually see them on we see them in 1 week. We see them in weekly for about a month, every other week for 2 months, and then monthly thereafter, as long as their drug screens are consistent. Usually the maintenance doses are between 12 to 16, although they can be lower or higher depending. My little ladies who got addicted through for osteoarthritis, they tend to be more on the side of 8 milligrams or 6. The heroin users tend to be more on 16 to 24. We confirm that they have attended therapy. We do film counts if we need to, and urine drug screens at that appointment or in between as well. And we give them a prescription until their follow-up appointment. The maintenance period is really determined by the patient's needs. So some patients want to be seen weekly, some do not. As long as their drug screens are consistent, you can push it out to monthly. So you want to ask the patient about withdrawal symptoms. Are their cravings well controlled? Have they had any relapses? Do they have consistent drug screens? Pull the PMP, assess their psychosocial changes. Have they obtained a job? I talk a lot about that if they're unemployed, especially with heroin and homeless patients. What are your goals after we start this treatment? What do you want to do to help? What can we do to help you re-enter society and become financially independent? Do you want to reach out to family once again? These sort of things are really important to really help that patient not just prevent relapse, but to continue to adequately treat their addiction and for them to become independent. We do urine drug testing, and we give their prescription until their follow-up appointment. There's a lot of controversy about when to taper a patient. There's no good data out there. Some patients can be, their goal is to be tapered off, and that's fine. And there's other ones who may not be ever able to taper. And there's, as I said, there's no real good evidence. The only evidence that's really out there shows that a rapid taper does not work. So if you start someone and then taper them within 6 weeks, they will relapse. That's the only really distinctive evidence that I've seen so far. So I really tailor it depending on the patient. So if it's dependent on what the patient wants, their psychosocial needs, their support system, and if you do decide to taper, you do it very slowly, about 2 milligrams per month at a time. I do not recommend starting a taper until a patient has been stabilized for about 12 to 18 months. And the reason why is studies have shown that that's about how long it takes time for the brain to heal, and also for them to complete all of their therapy services, and which is really the necessity that they need to treat their addiction. So it's really dependent on the patient. It's been mainly the patients who have been on pills that I've been able to, that have wanted to taper off and successfully done it. Patients who have been on heroin, it's much harder. And I think I've had maybe 1 or 2 patients taper off completely from heroin. I apologize, this is a little bit difficult to see, but you should have access to the slides after. This is just a visit flow, a checklist, so to speak, in order to make sure that we are doing all the things that we listed in that very long protocol document. This is a quick checklist that we can do. I'm a big fan of checklists. I was trained by Dr. Lee at the University of Iowa, and that he has a lot of data that shows how important checklists can prevent us from missing things. So this is kind of the checklist that we follow for the first visits as well as the subsequent visits. As I said, patients will be expected to participate in counseling or other recovery-oriented activities, and I don't determine that. That's determined by their counselor. So if a patient returns with a drug screen that's positive for other substances, they may be required to intensify counseling and return more frequently. It's very rare. We've never discharged a patient. We've only transitioned them to higher level of services. So meaning an inpatient for a period of time, or methadone perhaps, depending on what the patient needs. If a patient's drug screen is negative for Suboxone, then the patient may be dismissed because there's concerns of diversion. So previously, before 2017, there's a FDA black box warning for using opioids and benzodiazepines. However, the FDA came out with a special recommendation in 2017 in September that urges caution from withholding opioid medications from patients taking benzos or CNS depressants, because although the combination can have serious side effects, the harm caused by untreated opioid addiction can outweigh these risks. So the insurance prior auths are a little lagging in this. They a lot of times require them to be off or a taper to be set up, so just document that. And it's really important that you discuss risk with patient and document that the goal is harm reduction. So the goal is to prevent opioid overdose and death, and that's more of the problem than them being on methadone and benzos or Suboxone and benzos. We do what's called team-based care. So we have weekly staffings where we discuss these patients all together for about an hour. We do half of it's chronic pain, half of it's MAT patients. We review drug screens and counseling reports. It gives us time to discuss challenging cases and then plan the care for the following week. It's important to create relationships with your other partners in the community. So your substance abuse treatment units, those are going to be the professionals that help with the therapy, residential treatment units, the county jail, Department of Corrections, halfway house, homeless shelters, your local hospital and ER. These are great ways to really work on that, improving patient care, as well as offering that full circle loop of services. So if a patient goes to jail and comes out, that there are services available, because it's usually within the first, 8 to 72 hours of leaving the hospital or jail that they're at significant increased risk of overdose and death. So what are some missed opportunities? So in 2015, there were about 33,000 fatal overdoses from opioids, according to the CDC. On average, about 91 people are dying after an overdose of opioids each day, and for every fatal overdose, there are believed to be roughly 30 non-fatal overdoses. According to a recent study in JAMA, which looked at Medicaid data in Pennsylvania from 2008 to 2013, only about 33% of heroin overdose survivors and 15% of prescription opioid overdose survivors had been dispensed buprenorphine, naltrexone, or methadone within 6 months of an overdose. And this is a really big missed opportunity, because when they're in this sort of crisis situation, this is your opportunity to be able to reach out and help the patient. They're much more likely to be retained in care, as I'll show you in a few minutes. For most communities, immediate intervention with a combination of MAT and therapy are limited for those patients who suffer from a non-fatal overdose, and this is a missed opportunity within the healthcare system. So as we talk about partnering together, clinics partnering with the ER, clinics partnering with the hospital is extremely important to be able to really help those patients as quickly as possible. So this was a study done that was produced in Health Affairs, and it shows a number of patients who have been seen in the ER or inpatient for opioid or heroin overdoses. And as you can see, it's pretty significantly increased over the past several years. It looks like we may have missed a slide. Can you go back 2 slides, please? Let's see.
My apologies, Dr. Costalla. It may have somehow gotten pulled out as we were finalizing.
Okay, so I guess there was a big study that came out. I'll just briefly mention it. The big study that came out that showed that was done in Boston, and there were 3 arms to the study. So one was standard of care, meaning the patient who came into the ER and had an opioid overdose was given a handout of local resources. The second was a counselor talked to them for 15 minutes before discharge, and they were given the handout. And the third was they were given their first dose of Suboxone with an appointment within 72 hours to be established with a primary care physician to continue the MAT. At the end, about 60% of the patients who were given the MAT, the buprenorphine, and then discharged within 72 hours with a follow-up had about 60% retention rate on the medication at 6 months, compared to I think it was 11% with just the standard of care or the therapist giving them that handout. So the study did show that collaborative model between the ER and the primary care office did make a significant impact. It'd be really interesting to see longer studies with that, as well as in different communities. But that is a very, I guess, inspiring sort of study to show that it does make a difference if you intervene right away, right after they have an overdose. Okay, you can go to the next slide. This was also published in Health Affairs, and just shows that the number of patients has significantly increased who had presented to the ER or inpatient with opioid dependence, abuse, or poisoning. So MAT is a really important medication kind of system to offer patients. It helps with withdrawal while patient is undergoing counseling and substance treatment, and it's buprenorphine naloxone is safe and effective in suppressing withdrawal symptoms and blocking the effects of illicit opioids. It's a safe medication. Overdose is very low likelihood, and it's mainly been attached to benzos, but I said the FDA changed their recommendation, so it is okay to prescribe that as long as you document appropriately. Patients can continue to function on the medication, leading to stabilization in their home and work environment. It doesn't cause disruption to cognitive and psychomotor performance or cause any sort of end-stage organ damage. There is a diversion potential, but it's much less than prescribed opioids and methadone. You can do it within a primary care office setting after you received appropriate training. And honestly, you have a really big opportunity to make a change in your patient outcomes as well as your community. So thank you for listening.
Thank you, Dr. Costella. I think you shared some really great points on what medication-assisted treatment can look like and how to get that started in a primary care clinic. We did have a couple of questions come in that we'll answer at this point. And then if you do have any questions, please feel free to use the chat box and we can address those following our next presenter. So our first question was, you mentioned missed opportunities. If opioid use disorder is found in a patient in the hospital setting, how can hospital staff refer or assist a primary care provider in treating the patient?
Sure. So the first step would be, if it's possible, starting having some of the inpatient providers get licensed to do buprenorphine and start the prescription before they leave. So that'd be the first step. The second step after that would be getting a list of the providers in the community who do MAT or buprenorphine as an outpatient, and working on a workflow model that who is your contact person when you discharge a patient and they can go there. So kind of having that relationship with that clinic in order to be able to discharge the patient there, and then for them to continue to get treatment there afterwards.
Wonderful, thank you. And as a reminder to all of our participants in our Opioid Guardianship Project, our second cohort, we did send out a resource guide that has the locations of medication-assisted treatment providers in your county, as well as disposal sites and any pharmacies participating in the naloxone statewide standing order. So if you have not seen those, make sure that you connect with your primary contact, and we can make sure that we get those out to you if you have not seen them yet. Our second question is, how can hospitals make a connection with their local primary care provider if they have not yet met them?
Oh, so that's you. So what I would do, you mean the primary care provider hasn't met them before?
What it looks like, yeah.
Okay, so that's pretty common actually, even in our clinic too. So what there's usually a contact person. So I would set up a relationship with your local, whoever you'll be like your local go-to people, and say, call them up and say, hey, I have this patient that you haven't seen them before. I'd like you to do a consult. We're going to start them on Suboxone before they leave. I'd like them to be continued because there's this risk of opioid overdose, and then create that collaborative. So for example, we created a collaborative project with the jail. So the jail starts naltrexone, and we see them within 72 hours of discharge from the jail, from the Marshall County Jail. So you can do that same sort of process, just kind of work together and we took like 4 noon meetings to really hammer out the details and the standing orders and the releases and all that. So getting that stuff, getting sort of a process set up, and then just say this patient's going to transfer you to you and see you for addiction treatment. And they're usually very happy to do it, so it's not really an issue. People are doing that because they want to help, so it shouldn't be too much of a problem.
Wonderful, thank you. And then our last question that came in is, do you know of any emergency departments in the state of Iowa currently offering medication-assisted treatment induction?
No, not yet. I'm really hoping that they start doing it. I'm in Marshalltown, and I talked to Lance, who's the ER director here, and we just don't have enough patients who come in with overdose. I think it's like 1 or 2 per year because it's a small, rural hospital. So it's not really as worth it for them. But in the bigger towns like Des Moines, Cedar Rapids, Iowa City, Dubuque, Waterloo, those would be really great places to get something like that started. And I'd love to see that started throughout the state. Broadlawns would be a great place to do that too, but I don't know of any that have started that sort of system yet.
Wonderful, thank you. I think that's all the questions we have at this moment, but thank you again, Dr. Gostalo, for sharing your expertise and your time with us. And if there are any additional questions, please feel free to put them into the chat box and we can circle back to them following our next presenter. So our next presenter is Melissa Sprenger. Melissa received her master's degree in clinical psychology in 1995. She holds an international advanced alcohol and drug counselor certification for the past 22 years. She has worked with adolescents and adult patients presenting with multi-occurring conditions. Melissa serves on the Iowa Board of Certification Advisory Council and Board of Directors. She is currently the coordinator of Mercy Turning Point Treatment Center, including medication-assisted treatment services, and is the clinical opioid lead for the Mercy Medical Center, Dubuque. Welcome, Melissa, and thank you for joining us.
Hello, this is Melissa. Good to be with everybody this afternoon. Would like to again thank Dr. Gostalo for her very comprehensive medication-assisted treatment overview. She's so calm in her presentation with it, which is really just reassuring. And I think her ability to do that for us reinforces and validates why, you know, it's pretty easy to do. You know, there's a lot of models and protocols already mapped out for us, so we don't have to recreate the wheel. We can use existing documents and guidelines from SAMHSA and HIDTA and the National Institute of Health and look at what other programs are doing in the state and use them as great resources. I had the opportunity to meet Dr. Gostalo at this year's Governor's Conference on Substance Abuse in April, where she received a certificate of public health recognition for her work. And again, really want to thank her for the great overview today. On Monday, we had the opportunity to have Governor Kim Reynolds here at Mercy in Dubuque to sign the opioid bill legislation. And it was very interesting because all the media was circling around her and they were asking her, why did you come to Mercy Dubuque to do this? And her response was regarding medication-assisted treatment. And we started a medication-assisted treatment pathway, outpatient pathway here at Mercy in December of 2015. Governor Reynolds had heard a lot of testimony and information regarding that pathway, and she'd like that to be a model throughout the state. And that's why she came here, even though the actual legislation does not include anything regarding medication-assisted treatment. So we were very grateful to host her. And again, it underscores the importance of our work. One of the important things and really great things about being involved with the Iowa Healthcare Collaborative as one of their cohorts is we get to collaborate and share best practice together and really do this heavy lifting together, if you will, as we work on building capacity for medication-assisted treatment throughout the state of Iowa. Next slide. So, you know, here's some pictures. Initially, when we started our medication-assisted pathway in December 2015, we were seeing patients coming in for IV heroin, IV morphine misuse, using illicit substances off the street, and a lot of IV use with many hepatitis C cases that we were screening for, even some HIV and even some tuberculosis. So very, very chronic, becomes a public health epidemic, if you will. More recently, what we're seeing, the presentation of the patient is really has to do with prescription opioids. And so whether we're talking, you know, heroin from the street or whether we're talking opioids from a legitimate prescribed source or from off the street, we're seeing all of that presentation, you know, presenting to our care. Next slide. We know that physicians, prescribers are not prescribing as many opiates, so we're, you know, they're using the new CDC guidelines. There's really been a lot trending about safe opioid prescribing practices and why that's important for certain procedures such as maybe uncomplicated vaginal deliveries through OB, you know, really do not need to be going home with large quantities of opioids following those procedures. But because we're not seeing as many opioids prescribed, we're seeing an explosive increase in heroin, largely cut with fentanyl and illegally manufactured fentanyl, and also, illicitly manufactured pills from the street. And when you look where we're at in Dubuque and eastern Iowa, and maybe Doctor would even think in Marshalltown, and as we move westward, one of the largest hubs for heroin and illicitly manufactured fentanyl and pills is Chicago and Milwaukee, and then closely followed by St. Louis. So you look where we sit in Iowa here with the pipelines of Interstate 80 and Interstate 35, it's not surprising that we would have a significant amount of drug trafficking through our state. And we really are treating some of the most complex and chronic patients in the country. We've been advised by the DEA, our federal HIDTA officer, and the FBI that we are really treating some of the most complex patients in the country. The heroin, the fentanyl, China makes the illegally manufactured fentanyl. They send it to Mexico. They combine it with the poppy, and they are shipping it right to the Midwest, where they're trafficking it almost like a pizza delivery business. So they're really staying off the East and West Coast. And it's not uncommon to see patients presenting for our care that might have an opioid use disorder coupled with a mental illness and also a pain syndrome, a chronic pain syndrome, and to be presenting with those multi-occurring conditions. And so it really lends itself to our need to build capacity for medication-assisted treatment. Dr. Gastala showed a slide and a map of the nation that showed which counties have waivered physicians to be prescribing buprenorphine. And when we started this care in December 2015, there were 9 prescribers in the state of Iowa that had their ex-DEA waivers to prescribe buprenorphine. Now that number is closer to 65, although not all of those waivered physicians are actually actively prescribing buprenorphine, but at least they have secured their waivers. So you compare and contrast that to maybe our neighbor, Illinois, who has 600 waivered physicians. So we have much work to do here, and the onus is on all of us. We really have an opportunity to engage not only medical doctors, as we know they're very busy, but also mid-levels, physician assistants, and nurse practitioners to be able to build capacity for providing medication-assisted treatment throughout the state, potentially even using telemedicine to hit rural areas if that's a possibility. Next slide. So Dubuque, in July of 2015, we were named a high-intensity drug trafficking area by the White House Office of National Drug Control Policy. And that just means a lot of drug trafficking and a lot of overdose mortality in our area, really showing up as a federal hotspot, if you will, for drug trafficking and overdose death. Because of that, we were able to be eligible for some federal dollars to begin our medication-assisted treatment pathway. Even though that looks like a lot of money, it's, I think, closer to $800,000 now with some amendments we've had to those funds. I want to reiterate to all of you, we did not need that money for infrastructure. We used existing spaces, existing staff, a hand-me-down digital blood pressure machine for our area to provide this care very quickly. So really that money was used and has been used to pay for medicine for uninsured and underinsured individuals until we can get them do a presumptive Medicaid app and get some Medicaid going for them. So that's really been what that money has been used for, not so much the infrastructure of creating an outpatient MAT pathway or medication-assisted treatment in a primary care setting. We used about 11 departments in our hospital to coordinate this effort very quickly. I think when we received that money, we rolled out the plan within a month, again, using mostly federal resources that were available to us. And to date, in about, almost 2.5-year period, we've treated 230 patients. They've received timely medication-assisted treatment care. The majority of them, it has been buprenorphine with the naloxone or Suboxone. As doctor said, it's less likely a patient would be able to misuse that medication with the naloxone on board. And we've seen patients have a positive therapeutic response to that medication. And we know that buprenorphine increases dopamine in the brain. And that's one of the reasons why our 3 waivered physicians and nurse practitioner find it to be so useful is that, you know, dopamine is what gives us our get up and go, our gumption, our initiative. It's what gets us out of bed in the morning. It's what helps us keep our appointments and our obligations. So we have seen buprenorphine not only manage patients' withdrawal syndromes and see them having less drug craving as a result of that dosing, but also the decrease in drug use, the decrease in criminal behavior, improved interpersonal relationships. Our patients, we're working with some of the same patients that we started working with in December of 2015. So over this 2.5 years, those patients have remained engaged with our care. They've kept their appointments. They come to their therapy. They've secured employment. I mean, the outcomes are undeniable with this care. And so we really need to be using that science of medication-assisted treatment, how we can have improved outcomes, improved patient satisfaction at less cost in healthcare systems. So patients aren't always in being high utilizers of the emergency department setting, overdose state in our intensive care units, even admitted to our psychiatric inpatient unit if they do not need to be. So these outpatient settings and pathways and primary care settings are wonderful opportunities to provide this care where we begin to see significant results very quickly. I have never seen the suffering that I've seen with patients that come in having misused heroin or morphine or oxycodone or hydrocodone or heroin for a period of time, and they come in and they are so ill in withdrawal. They are so ill. They're vomiting. They have diarrhea. Their legs are twerking. They're sweaty. They're clammy. They're miserable. And to see then after doctor said an additional dose in that induction, wait a half hour, another dose of that medicine, maybe a little bit longer, another dose, and to just see the improvement of those symptoms so rapidly is really, as a healthcare provider, it's very rewarding to see that with patients. Next slide. You know, we talked a little bit about, you know, who are we treating? Who's coming into our care? And I have just a couple listed there, and I don't need to go through them all. But initially, again, like I said, you know, a 19-year-old post-heroin overdose, resuscitated with naloxone. This particular patient had overdosed in his vehicle. Thankfully, his vehicle was not in park. So as he went into his overdose state, his foot hit the gas pedal and he crashed into a house here in Dubuque. Thankfully, because if he had not have done that, he probably would have passed away. But because he hit the house, it brought attention to his situation. He was resuscitated, and we were able to get him started on Suboxone almost immediately after that. This individual has now had 2.5 years clean. He was one of the first patients that we saw in our MAT pathway. He had not graduated high school. He now has secured employment. He was named Employee of the Month. He just got a promotion. He has spoke publicly with the governor regarding how medication-assisted treatment has saved his life. It's given him his life back so that he can be fully functioning and have achieved wellness, he believes, because of taking that medicine. He has now successfully tapered off. We got him down to, I think, 1 milligram, 1/2 milligram, and he chose to go off on his own and has done quite well. We've continued some counseling support, though. And again, like Dr. Gostella mentioned, you know, there's no good evidence out there, science, to support when a patient will successfully taper off this medicine or if they should remain on it long-term or indefinitely. Our physicians are of the mindset that it takes 12 to 18 months for your brain chemistry to come back to a healthy balance, for your brain to heal. So we'd at least want to be to that point before we would even begin a taper. And doctor did talk to us about what a taper schedule might look like. We'll look at the last one there, a 70-year-old female prescribed morphine suppositories for 40 years. For 4 decades, she took morphine suppositories prescribed by her PCP to treat her pelvic disorder. And because of the CDC guidelines, because her prescriber retired and she got a new prescriber and was no longer going to get this medication prescribed to her, she went into a withdrawal state. We were able to avoid a hospitalization for her by bringing her through our outpatient pathway, starting her on the Suboxone, which she has continued on with good results. We're not a pain clinic, but we do know that Suboxone does too help with pain. And she has found that to be the case for her pelvic disorder, that even that she has found some relief from the Suboxone, not only managing her dependency on morphine that she developed, even as taking it as prescribed, but for that period of time. You know, some of our federal experts talk to us about when you take opioids 3 days, 5 days, 7 days, you just begin to increase your risk for dependency on that medication and the risk for an opioid use disorder. So to look at somebody who had taken them for 40 years, it's really significant. Just a delightful lady. We've engaged her husband. Here in treatment, we like to have a living room style. We have a couple couches, we set out a platter of cookies, we have some soda, coffee, and we just welcome patients to come into our care themselves, their family members, their loved ones, their boyfriends, their girlfriends, their children. Many of our mothers bring their children along. We had to buy some Legos and some children's books to have on hand. But we really want to create a space that is welcoming, that is engaging, and that they know that it can be their home base and they can come here whenever they need to. Next slide. Doctor gave us a very comprehensive overview of opioid pharmacology. I did just also want to mention, though, disulfiram therapy or Antabuse and acamprosate Campril. In terms of, we're also treating alcohol use disorder with medication, with FDA-approved medication, and Rivia, which can also be used for opioid use disorder. So we talked about the opioid ones, but I also want to mention those top two in terms of when we're doing medication-assisted treatment. You know, we want to have all those in our toolkit to be offering to patients. We do not do methadone here in our clinic, as Dr. mentioned. That's in a methadone clinic only. Unless a patient comes in already on methadone, we can help them maintain it or taper them off of that medication. You can see the Suboxone films there on your right, an 8 milligram, a 2 milligram. It's always curious to me how the smaller strengths are bigger films. Sometimes the packaging, that kind of plays with my mind a little bit, and with patients, especially when you are going to begin to taper them and the film sizes change, and so they begin to ask a lot of questions around that. We have used the pill formulation for a handful of patients that have had allergic reactions or medical reasons why they cannot use the component that makes up the film technology. Either they gag on it and vomit it, or they are allergic to it. But for our Medicaid enterprise, obviously the films are the preferred delivery, and so that is primarily what we are using. Next slide. I did include here our Suboxone induction order set, and you can see in the admit section, place an inpatient status, place an outpatient status. We are doing the majority of this work in the outpatient area, but we can use our inpatient psychiatric area if we need to, if there's some reason why that patient would need to be maybe psychiatrically in a controlled environment. But the whole idea behind this is we need to be doing this in outpatient care settings. And I also wanted to include this slide just for the laboratory work there about midway down the slide. We're looking obviously for pregnancy in patients. If a woman is positive for pregnancy or pregnant, our doctors prefer to use straight buprenorphine or the Subutex because it does not have the naloxone in it. And Dr. Costello and I have talked a little bit about this. I mean, there's just not really a lot of good information or literature out there regarding effects of naloxone on a developing fetus. You know, our doctors are preferring to use the straight Subutex, although we monitor those patients significantly greater just because of the diversion potential of that buprenorphine when it doesn't have the naloxone wrapped into it. And I will talk about diversion in just a minute. We're also doing a CBC with differential, a comprehensive metabolic panel. We're looking at HIV and hepatitis, and we have had many patients test positive in those areas. Sometimes we run into difficulty then referring. Many of these patients have burned bridges with providers locally. Maybe they didn't pay a bill, maybe they went to multiple doctors, were perceived as drug or doctor shopping, or we had one patient that had actually forged a script in his history with a practice. So sometimes we have difficulty referring patients for this follow-up care, and we actually have to look out of the community for that, which isn't always convenient if patients do not have transportation. Next slide. Okay, I want to spend a little bit of time here talking about our environmental controls to mitigate buprenorphine diversion. in January 2017, we were featured in a SAMHSA newsletter from the Division of Pharmacologic Therapies for our ability to mitigate diversion. And when you talk to people about the diversion potential of buprenorphine, a little bit of that goes with the territory. But obviously, to keep the integrity of what we're doing here, we want to make sure that when we're prescribing this medication, when we're dispensing this medication, it's the patient is taking it for their own use, they're taking it as prescribed, they're not sharing it, they're not selling it, they're not, misusing it. We really need to put a lot of emphasis on mitigating diversion. And so it's important to wrap resources around the primary care practice, the physicians that are the prescribers that are doing this care through the treatment setting, because we can do very aggressive case management with patients to assure that they are taking that medicine for their own use. We either e-prescribe the medicine to one pharmacy on site, or the doctor will print it on a tamper-proof prescription paper. And we use just one pharmacy because it's easier for us to mitigate diversion. We can troubleshoot with the pharmacy. We know if a patient has not picked up their refill of Suboxone. We know if they try and come early. If there's any discrepancy, we had one just the other day where a young African-American gentleman, I'd say probably mid-20s, came in and said, he's on 12 milligrams daily. He said, you gave me 28 days worth of the 8s, but you only gave me 2 weeks of the 4s. So he takes an 8 and a 4 daily. And so I checked the prescriber's documentation. I checked my documentation as the MAC coordinator. I checked with the pharmacy for their log and what they dispensed and how that script was written. And sure enough, he was actually missing 2 weeks of 4 milligram medication due to an error on the prescription from the prescriber. So it just has been very helpful to use one pharmacy. Of course, the pharmacy's locked up and secured, and they do daily counts, and logs are kept. It's very closely monitored. We do random counts of the Suboxone films. But we know patients can be pretty savvy, and sometimes they rent films from each other. So maybe we gave a patient 2 weeks worth of their medication, and we call them on day 8 and ask them to bring their films in. Let's say they've misused it or they've sold it. They may rent films from another individual to bring in so that the count is accurate. So, some of these mechanisms are good and great, but we have to look at the whole picture. We have to look at their presentation. We have to look at their urine drug screens. We have to look at what their family members are telling us, how they're progressing in their therapeutic process and their cognitive behavioral therapy, how things are improving in their life with their interpersonal relationships and their employment, and look at the big picture here. Also, it's not uncommon. Some pharmacies across the nation will actually photocopy the packaging that the Suboxone films come in. They have numbers on them, but we know when patients sell buprenorphine in the community, they usually take it out of the packaging, secure it in a baggie before they sell it. So that's a lot of work on the pharmacy end or on the treatment center end to be doing that, and oftentimes doesn't yield results. We do a little collaboration with our area Dubuque Drug Task Force, certainly not sharing confidential patient information, but it's not uncommon for the task force to call me and say, hey, Melissa, this weekend on Saturday, we intercepted a Suboxone cell. It was in the children's book section of the library. It was 2 12 milligram films. It was a mid-aged woman. And I might think to myself, we don't give out very many 12 milligram films. How many women do we have that we're dosing 12 milligram films to? It's not a deal breaker in terms of the patient. Obviously, we're not discharging patients out of care for suspected diversion of this medicine. But if we have a confirmed diversion, that's about the only way we would discharge somebody from this pathway. We obviously encourage lock boxes for patients. If patients lose their medicine, if their medicine gets wet, we had one patient, his wife didn't like him on it, so she threw it in a fire and burned it up. It's very difficult for the prescribers to fill that prescription early if they've run out or used it, or maybe they're on 16 milligrams a day, they use 8 themselves and they sell the other 8. So it's very, very difficult for us to fill that early. So we do a lot of scripting with patients. We actually do a patient contract that talks about some of this. keep it in the child-proof container. We don't want your child, your pet, anybody getting into the Suboxone. Keep it locked, keep it on your person. If you're traveling with it, it's not uncommon for men to put a couple in their wallet when they go to work. But if they are pulled over for some reason, they can be charged with possession of it if it's not in their medication bottle. So it's a lot of information on this slide, but this is really one of the hallmarks of what this care is just making sure that we are mitigating diversion of it. And I feel like if we have the patient in treatment, we're doing the aggressive case management, they're working with their prescriber, we're looking for buprenorphine in their urine, these sorts of things, chances are we can feel good about the dispensing and what we're doing with this medication. And I will say, of those 230 patients that we've treated, we've had 4 confirmed diversion cases and 4 suspected diversion cases, just to give you a little feel for how that goes with this. Next slide. We do naloxone training. We have 2 community education RNs here at Mercy Dubuque that do Narcan training for the community, for law enforcement, and those sorts of things. But we really want to make sure patients that have opioid use disorders get this training, that their family members get this training. So all of our MAT families are invited, their concerned persons are invited, and that we provide this medication to them using federal grant dollars. So there's no cost, but we like them to have this. And it really is the harm reduction model. So we used to tell patients, well, don't ever use heroin again, or don't ever misuse opioids again. Really, how we talk to patients now is, if you did use heroin again, you'd want to be really careful because you're opioid naive. You've been on Suboxone a year. If you went back to taking your old dose, it could kill you. Or if you do use, never use alone. Always do a test dose. Always have Narcan with you. That's kind of foreign messaging to me, having worked in this area for 25 years almost, that we would be having those conversations with patients. But this is some of the work that's coming out of SAMHSA, our federal partners who we look to, who provide our funding. This is the language that they're using, the messaging, the scripting they're using with patients now. So very, very important. And even I know Doctor touched on, when patients are prescribed benzodiazepines, it's contraindicated that a doctor also give them Suboxone. It can become fatal if you mix the two. But if you have a patient with a generalized anxiety disorder who takes a very, very, very minute amount of Klonopin every day to deal with that, from a harm reduction standpoint, it might still be a good idea to keep him on the Suboxone if he's monitored closely. Next slide. So in healthcare, obviously we want to be doing a lot about the science of medication-assisted treatment. We want to engage potential prescribers to secure their ex-DEA waivers to build capacity for providing this care. But we also want to be talking about a few other things. Reverence, when patients present to our ED settings, either post-overdose or in withdrawal, we want them to feel held. We want them to feel cared for. We want to stabilize them, no different than we do when patients present to our care with other diseases. When I mentioned Opioids 101, I think some of the work I've done at this hospital, I assume nurses, dietitians, chaplains, social workers, prescribers know these things. Don't assume that. Maybe some basic opioid one-on-one. What does tolerance mean? What does opioid naive mean? And how, by knowing that, by improving that knowledge gap, how can that positively improve our practice in the healthcare setting and better help our patients? We've talked about co-prescribing naloxone for people on opioid therapies for various reasons. It's not always cost effective just because insurance doesn't always cover it. And we do a lot with safety because we've had a lot of fentanyl and carfentanil exposure in our area. So first responders, our ED staff, EMS need to be very, very careful because even touching somebody that has misused that and is in an overdose state, if you even touching them can cause you to go into an overdose state, basically. So very, very important to, as we're working on medication-assisted treatment, we're wrapping these other pieces in as we're reaching out, as we're helping bring along the rest of our colleagues in the healthcare setting. Next slide. We talked a lot about the prescription monitoring program in our area, and we saw that in the opioid legislation that will now be a requirement for prescribers to be using the PMP. And there's been a lot of improvement to that system in our state just recently for ease of use, but doctors and their electronic health records should really have a link to this if it's not built into your records, so that you can have your prescribers using that with ease. It is very much something we use in the medication-assisted treatment pathway and in our substance use disorder treatment setting, and in psychiatry even, but we want doctors working in family medicine, internal medicine, OB, all the areas, acute care, to be using that PMP. We know that there's many non-pharmacological ways to relieve pain for patients. We've worked with the Iowa Healthcare Collaborative to learn how we can redefine how we talk about pain at the bedside. We're working more on helping patients manage their comfort, and by providing them a comfort guide and comfort goals. We also have some opioid-specific discharge instructions that we're using. And again, although this isn't medication-assisted treatment specifically, it all ties together. If we're doing a better job of welcoming in the patient, stabilizing the patient, engaging the patient, assessing the patient, there's a better chance we're going to be able to make that referral to those waivered physicians to begin the medication-assisted treatment pathway if that is warranted. Next slide. There's been a lot of collaboration, and like I said, I've done a lot of work in our community, doing outreach, other communities, through our sister hospitals. We have 22 states where we have Mercy hospitals in throughout the country, done just a lot of collaboration and education, but we cannot forget internally, making sure all of our internal customers, all the departments, all the medical teams, all the physicians, that we're all on the same page with this care, with the knowledge. If there's a knowledge gap, we want to fill it right in and make sure we're wrapping good resources around our healthcare team to be able to execute this evidence-based care kind of in a streamlined way and efficiently, because we do have very solution-driven results. We're talking about life or death here. We've had 28 deaths in Dubuque, now 30 deaths if you count this year, over the past few years. I mean, it's way too many people. Many of those patients, had we have had the Good Samaritan law in place, had we have been using the prescription monitoring program, had we have had effective medication-assisted treatment, might still be alive today. So we want to continue with these process improvements because it is life-saving work. Next slide. The warm handoffs are very important. We've done some more significant work with our own ED. We always used to be closed on Fridays. We're open now on Fridays. We're working with our community block grant funded agency, SASE, here in town. They have opened up some more evaluation hours. If we don't have the availability they do, somehow somebody's getting into this care when they need it and in a more timely way, because we know it saves lives. And, you know, we're really going to continue to be transforming and compassionate in how we do this in our community, and it will definitely have a multiplier effect. If we're all starting to build this capacity and do this work, it will begin to multiply, and we will be positioned well, all of us, when the opioid epidemic hits Iowa, which is forecasted for another 3 or 4 years down the road. So it's really important. Any effort that we put into this now will serve us well in the next decade. They say it will take a decade to work out of this opioid public health crisis. So anything we do now, whether you're engaging prescribers to get their XDEA waivers, you're working with your medication safety teams, your pain committees, your accreditation coordinator, you're putting information in your medical staff newsletters to continue to drip this information on prescribers. Not mandate it, maybe not require it, but certainly engage them and share the good information, share the science. When I would talk to prescribers about securing their waivers, and I would say, oh my gosh, this is so sad. This mom just buried her only son. I wouldn't get very far with that. But when I share the science of it, it's undeniable. It is convincing. So that's something I would encourage all of you to do as you move forward. And if you need anything, if you want a copy of our contract, our consent form for opioid pharmacotherapy, how we do our pharmacological management appointments weekly, anything that we can help provide you from Mercy Turning Point in Dubuque, we are happy to share. And with that, a final quote on the next slide. This is the good old Sister Catherine McCulley, the foundress of the Sisters of Mercy, and back in 1831, she said, "It is better to help 100 impostors, if there are any, than to let one really suffering person be left without help." And, you know, yeah, we've had a few people present for our medication-assisted treatment pathway that probably wanted the medicine just to sell it, maybe to supply another habit of theirs or offset other needs they had, who knows. But we have to assess them. We have to do the clinical opioid withdrawal scale. We have to get them in our door and engage them and get them in our therapy setting and try it. It's better to help 100 imposters, if there are any, than to let one really suffering person be left without the help and the care, the good care that we all do. So with that, thank you, and maybe we have time for some questions if there are any.
Thank you so much, Melissa. Your passion and just your drive for this work is always great to hear, and I appreciate you taking the time to present with us. I think you hit on some very important things throughout your section of the presentation on multiple conditions and looking at opioid use disorder as another chronic disease that we need to help manage. And then you talked a little bit about that you did have some funding, but that wasn't really necessary to still have the infrastructure and have use of your current resources. So a good reminder for a lot of our participants on today's call. You also mentioned SAMHSA quite a bit, and just wanted to share that I did post on the discussion on innovation that SAMHSA has released 13 new patient-friendly handouts in their RX pain medications, Know the Options, Get the Facts campaign. So if you have not had a chance to take a look at those, hop on to Innovation and take a look at these amazing handouts that you can share with your patients to really help them better understand opioids, alternative therapies, and some of the nuances like the prescription monitoring program, et cetera. With that, we are happy to take some questions. I have not seen anything come through the chat recently. If you do have a question for either Dr. Guastalla or Melissa, please feel free to add that to the chat. I just have a couple of slides to wrap up, and I'll monitor the chat following that. So as a reminder, in our opioid guardianship project, we are getting to the wrap-up phase as we are halfway through May. The project does wrap up at the end of June. So just a reminder that we will be sending out a project post survey. It will be due back to us on June 8th by the close of business. We are finalizing that currently, and we'll have that out as soon as it is available. We also will have a project review on Thursday, June 21st from 11 to 12. Please join us, as we would like to hear your input and your thoughts on what went well and what we could improve upon through this second cohort. As always, myself and Lana are available to help with any questions or assist you as you start to go through the next phase of this project. And we are just so appreciative that we've had so many active participants engaged in this project and making a change in their local hospital communities and with their patients. Again, if you have any questions, feel free to pop them into the chat box there. Melissa, I did have one question come through asking, you mentioned sharing tools and you mentioned pathways and things like that. Could you describe what you mean by pathway and what those look like within your Mercy system?
I know doctors shared kind of a flow chart. So when I talk about a pathway, we have a tree that looks similar to that, and basically just how referrals come to us. We take a referral from a patient themselves, a walk-in. We were in the media a lot on Monday with the governor here, and that was very fun to kind of celebrate that and the success and all the things that have happened in a very short period of time to bring solutions to our community and to save lives. But the very next day I came into work and we had 8 patients here or walk-ins wanting Suboxone care. One, a woman that has been using IV morphine that'll be delivering at the University of Iowa on Tuesday. So very, very severe cases and shows us that there's still a need. So a patient can just walk into our care. We can get a referral from corrections, from the drug court here in Dubuque, from a primary care provider, from the local pain clinic. We have patients that might drive an hour or an hour and a half to access our care. We try to provide some gas cards for those patients to make that a little bit more doable. But when I talk about pathway, I really just mean kind of our flow tree, our flow chart, kind of how we do things with, as Doctor mentioned, you know, initially we'll do just weekly prescribing, then we'll move into 2-week prescribing if there's progress, and then 28-day dosing if things are going well and we're in more maintenance dosing. So when I mention pathway, the Substance Abuse or Substance Abuse Mental Health Service Administration has several tip manuals that kind of show what that flow chart might look like and how you can adapt it for your own setting. And but again, I know Doctor has hers in a slide there that you could look at.
Wonderful. Thanks, Melissa. With that, I am not seeing any other questions come through. If you do have any questions following this presentation, feel free to reach out to Lana or myself, and we can get the answers from our presenters today. Again, I want to thank Dr. Guastalla and Melissa for taking the time to share their expertise and how to manage a patient that when we do identify opioid use disorder, what are our next steps? How can we come together as a community and as a healthcare system to really make an impact on these patients? Just a reminder that to obtain nursing contact hours from today's presentation, you must have entered your nursing license number at registration. You must be logged in individually with a unique email address to the webinar for the full duration of the presentation, as no partial credit will be available. And a nursing contact hours certificate will be emailed to you following today's presentation. If you are a non-nurse and you are looking for a certificate of attendance, we plan to have all of this out following the presentation today. It may take us a week or so to get those all set up and emailed out to you. You'll be able to print those to show completion of today's presentation. You will need to complete an evaluation if you are looking for that certificate of attendance. With that, I hope you all have a wonderful rest of your Thursday. Enjoy your weekend, and we will talk to you all very soon. Thank you.
Thank you, Sarah.